Welcome to Module 6 in Pain Control and Dentistry. We will be covering Chapters 5 and 7, Local Anesthetic Agents and Pre-Anesthetic Assessment. Local anesthetic agents are distributed in single-use dosages. These cartridges hold 2.0 milliliters of solution. The addition of the rubber stopper reduces this amount to 1.8. Current dosages in these cartridges has been even reduced further to 1.7 milliliters of solution. However, we will continue to do our mathematics on 1.8 milliliters. The local anesthetic is measured in a percentage of local anesthetic agent in each cartridge. A 2% solution will hold 36 milligrams of drug in the cartridge. A 3% will hold 54 milligrams of drug. A 4% will hold 72 milligrams of drug, and a 0.5% will hold 9 milligrams of drug. When looking at the carpule, the name of the anesthetic and the percentage of drug, with or without epinephrine, will be clearly stated. The composition of a local anesthetic agent is clearly stated on its label. The ingredients include the local anesthetic agent in a percentage form, the vasoconstrictor that is included, the vasoconstrictor preservative or antioxidant, and also sodium hydroxide, which is used as a buffer in isotonic solution. There are 5 generic classifications of local anesthetic agents: lidocaine, mepivacaine, prilocaine, articaine, and bupivacaine. When selecting the right local anesthetic agent for your patient, there are many things to consider. We want to look at the duration of pain control that is needed. We want to look at the need for post-treatment pain control, the patient's health assessment, the current patient's medication, allergies to any local anesthesia, and the inclusion of its additives, and if the need for hemostasis is required. Short-acting anesthetic is limited to about 30 minutes or less of pulpal anesthesia, but can have up to 3 hours of tissue anesthesia. There is no presence of vasoconstrictor, and the local anesthetic agents that fall into this category are lidocaine 2% plain, mepivacaine 3% plain, and prilocaine 4% plain. The duration of intermediate acting anesthetics is between 45 and 150 minutes, and this is dependent on the amount of vasoconstrictor that is added to the local anesthetic agent. They have about 4 hours of soft tissue anesthesia, and all the intermediate acting anesthetics have vasoconstrictors. They range between 1 to 50,000 ratio to 100 and 2,000 ratio for epinephrine, and the only one is levonorepinephrine, which is the artificial epinephrine. That is 1 to 20,000 ratio. The only medication that falls into the long-acting local anesthetic and has a pulpal anesthesia of over 90 minutes and 6 hours of soft tissue anesthesia is our bupivacaine at 0.5% in a 1 to 200,000 ratio. It contains a small amount of vasoconstrictor, but the drug itself is extremely powerful. There are several other factors that affect the duration of anesthetic agents. We look at the individual response. Sometimes we have a normal versus a hyper responder. This has to do with medications and the patient's psychological state of mind. Accuracy in the anesthetic that is administered has a big effect on the duration. We look at the selection of the anesthetic agent, the accuracy of delivery at site, and we also look at tissue density. Also, anatomic variations have a play on the duration of anesthetic agents. agents, and also the vascularity of tissue. The presence or absence of infection and inflammation in an area also has a big effect on the vascularity of the tissue and the length of the duration of the local anesthetic. In selecting the appropriate local anesthetic, we also have to decide whether or not we need post-treatment pain control. We determine this by the time that after the procedure is done, the length of time we need soft tissue anesthesia. So avoiding long-acting anesthetics sometimes is not necessary. When we do know that the patient may incur pain or discomfort, we may want to increase the amount of anesthetic or the type of anesthesia, the strength of it, to ensure that we have provided them with several hours of post-treatment comfort. We look at patient assessment and medical conditions in our selection of local anesthetics because we know they have a big effect on the patient. Cardiovascular disease, liver disease, hyperthyroidism, brittle diabetes, which is uncontrolled diabetes, and allergies are only a few of the pre-assessment conditions that we're going to review later in the course. Contraindications because of these diseases or medications or conditions have an effect. And when we look at selecting the anesthetic, some are safe without any problems. Some are categorized as relative, which means the administration of local anesthesia is done cautiously. We know that there's a potential for a risk situation to occur. If it is an absolute contraindication, that means under no conditions will we administer a particular local anesthetic. One situation that we encounter sometimes with patients, and this has to do with the type of additives that are in a local anesthetic agent, mostly bisulfite, is an allergic reaction, and this is due to the vasoconstrictors. Bisulfites are added to local anesthetic agents as a preservative. So patients that have a very sensitive sulfite allergy manifestates in the system as either respiratory or skin lesions. And at times, asthmatics, if they are steroid dependent, will also have a reaction to these bisulfite additives that are included in local anesthetic agents to preserve the vasoconstrictors. The choice of drug that will end up selecting for local anesthesia for patients with these type of allergies would be those drugs that do not contain any vasoconstrictors. They will be our plain local anesthetic agents. When we use vasoconstrictors, our main priority is to contain or establish some type of hemostasis, which is a bleeding control. Vasoconstrictors do not affect the level of pain control, only the duration and also the area for bleeding that we're trying to restrict. They achieve this through adrenogenic vasoconstriction that is done within the blood vessels. The alpha receptors are less sensitive to epinephrines, causing a large amount to be needed to create hemostasis. So epinephrine provides better hemostasis than levonorepinephrine, but when there is a situation that we cannot use epinephrine, our next selection in the case of needing hemostasis would be using levonorepinephrine, which is only in bupivacaine 2%. There are several different types of amide local anesthetic agents, but the only ones that are used in dentistry are lidocaine, bupivacaine, prilocaine, articaine, and bupivacaine. Within the scope of practice for dental hygiene, lidocaine, bupivacaine, and prilocaine are probably the most common used ones. At this time, articaine is being used, but with caution. It is limited in its application because of some of the properties and contraindications that it causes with our scope of practice with dental hygiene. Bupivacaine is not a drug of choice that we will ever select for our type of work. It is mostly for oral surgery, and it has extremely strong analgesic type of properties. It is a very strong local anesthetic agent, so therefore we're not going to be including that in our selection of drugs. Lidocaine is an Xylidine derivative. It is one of the very first local anesthetics that was created for nerve blocks. It is still today the standard for when all local anesthetic agents are compared. So it would be considered our gold standard of drugs. It is rarely used without a vasoconstrictor because of its short duration, and it does have very strong dilation properties on blood vessels. It is 2 times more potent than the ester procaine, which provides profound anesthesia, and it's no longer used in dentistry. It is an effective topical agent, and it's put into many topical solutions, and it possesses this anticonvulsant property, which helps stop seizures. So it's a good medication to use if your patient has epilepsy. I'd like to go over this chart on lidocaine and discuss a few things that we will actually go into more detail and application with this drug later. Xylocaine has a maximum dose of 300 milligrams. We also know that half the time, within an hour and a half or a little over, half the drug has already left the body. The onset time from when the time of deposition is about 2 to 3 minutes. There are several different brand names that lidocaine is packaged under, and xylocaine, octane, alphacaine are 3 of them. Also the concentrations. It always comes in a 2% concentration, and it comes in 3 forms: with vasoconstrictor, and there's 2 levels, a 1 to 50,000 and a 1 to 100,000. Both are quite potent. Or it comes plain. We know that with no epinephrine, the time for pulpal anesthesia is only 5 to 10 minutes. And when we do have epinephrine, the pulpal anesthesia time is increased to 60 minutes. It is similar potency to mepivacaine and prilocaine. It is only 2/3 as potent as articaine, and is only 1/4 as potent as bupivacaine. Its toxicity is equivalent to mepivacaine and articaine. We'll talk about toxicity, and it has to do with the patient's conditions and drugs. It is 60% more toxic than prilocaine. So prilocaine is a pretty safe drug as well. And it's 25% less toxic than bupivacaine. It is metabolized in the liver, as are all amides, except for articaine, which we'll talk later. And when it's secreted into the kidneys, it is less than a 15% unchanged solution. That means that as this drug is secreted out, our bodies have not metabolized up to 16% of the drug, and therefore we will find more of it backed up into the kidneys. The pKa is 7.7, which is pretty close to our 7.4 pH in the human body. So the drug has some sense of discomfort when it's injected, but not as much as other drugs, other local anesthetic agents. The next drug is mepivacaine. Mepivacaine is of similar derivative as lidocaine, and therefore it has similar properties. Mepivacaine is a very effective non-vasoconstrictive local anesthetic agent due to its low vasodilation property. Unlike lidocaine, it has more vasodilation than mepivacaine. So when it's used without any type of epinephrine or levonorphin, which is a synthetic epinephrine that's used in mepivacaine, it has great, much longer pulpal anesthesia and soft tissue anesthesia. It is not used effectively topically, as is lidocaine. But for our clinic purposes, this is a great drug of choice when you need to use a non-epinephrine or non-vasoconstrictive type of drug. It does come with a synthetic epi, and we'll talk about that with the upcoming chart. So let's review the chart on mepivacaine. Mepivacaine comes in a 300 milligram maximum dose. Its half-life is almost 2 hours, and its onset time is very quick, 1.5 minutes to 2 minutes. This doesn't mean the time to reach profound anesthesia, but we are at a point where the area is quite numb and can begin with work. The brand name that is most common is Carbocaine, and this is the actual solution we will be using in our clinic. The concentrations come in 2 formulas. One is a 3% plain, which means it does not have any type of vasoconstrictor, and the other solution is a 2% with a 1 to 20,000 ratio of a synthetic epinephrine called levonorphin. This is a very weak vasoconstrictor that is added in situations when patients cannot have much epinephrine or vasoconstriction or have some reaction to an epinephrine. The duration is quite short when we're looking at pulpal anesthesia, but when this is administered as a block, you have up to 40 minutes of working time. With the vasoconstrictor added, it's about 60 minutes and considered an intermediate level or duration type of anesthetic. Its potency is equivalent to lidocaine and prilocaine, but it is not as strong as articaine or bupivacaine. Its toxicity is also similar to lidocaine and articaine. It is 2 times more toxic than prilocaine and only 25 as toxic as bupivacaine. It is metabolized in the liver and is excreted in the kidneys, and the pKa is somewhere between 7.6 and 7.7. Let's move on and discuss prilocaine or prilocaine. It is similar to lidocaine and bupivacaine. It is also a very low dilator, and why you will see it in concentrations that are plain. It is a precursor to the occurrence of what disease is known as methemoglobin anemia. This is a genetic type of condition. These patients will encounter higher than normal methemoglobin in their blood, which will interfere with the binding of oxygen. You will notice that their lips and mucosa begin to turn blue, and it's literally a form of suffocation. So with patients in their medical history that we note that they may be susceptible to prilocaine is a contraindicated drug. Let's take a look at the chart of prilocaine. Prilocaine is a very good drug, and you have a high dose at 400 milligrams with a half-life of almost 2 hours. The drug has a very fast onset time. Synastin is the brand name that we purchase. It comes in 2 concentrations, 4% plain and 4% with a 1 to 200,000 vasoconstrictor, which makes it a very weak concentration. If this drug plain is administered as an infiltration, you'll have about 10 to 15 minutes of working time. If it's administered as a block, it will have a longer duration time of 40 to 60 minutes. When you use this drug with the vasoconstrictor, your duration working time is up to almost 90 minutes. The potency is similar to lidocaine and bupivacaine, and of course it is not as strong as articaine or as toxic and potent as articaine and bupivacaine. It is a very safe drug. You'll notice that it is actually 40% less toxic than lidocaine, and why it may be a drug of choice for many patients. When we look at the metabolism and secretion, the metabolizing of it with the lungs and the liver, it's much easier than lidocaine. And secretion, again, is in the kidneys, and a fraction is excreted unchanged. The pKa is between 7.7 and 7.9. Articaine. Articaine is a thiophene derivative. The formula differs from other amides because it has an extra ester link in its compound. It functions as an ester more so than an amide. It has high risk of paresthesia. Paresthesia is persistent anesthesia. So this drug, when administered, is not recommended for inferior alveolar blocks or any type of lingual block. Articaine comes with a 500 milligram maximum dose, which is probably one of the largest maximum doses of all the local anesthetics. And it also has the shortest half-life to about half hour, 45 minutes. Its onset time is quite quick at 1 to 3 minutes, and the most common brand name on the market today is Cefticaine. It comes in 2 types of solutions, same concentration in each, 4% with a 1 to 1,000 ratio of epinephrine, and a 4% with a 200,000 ratio epinephrine, which is an even weaker epinephrine. The vasoconstriction time on it allows for about 60 to 75 minutes of pulpal anesthesia, which constitutes it as an intermediate duration drug. The 1 to 200,000 epi offers a little bit less time at 45 to 60 minutes, and again, it is still classified as intermediate. It is 1/2 to 2 times more potent than lidocaine, bupivacaine, or prilocaine. Its toxicity is similar to lidocaine, and it metabolizes again in the liver with 5% secretion in metabolized in the liver. The kidney secretion is a 5 to 10% unchanged, and the pKa is at 7.8. The last drug we're going to review is bupivacaine. Bupivacaine is the most potent and most toxic of all amides. It is used for long-term pulpal anesthesia, allowing over an hour and a half. This is for more advanced surgical procedures and not within the scope of practice for dental hygiene. It has excellent post-treatment pain control, but it does have a very slow onset time due to its high pKa. Bupivacaine comes in a very small maximum dose at only 90 milligrams, which is quite lower than most of the other drugs. It is in only one concentration, which is a 0.5% at a 1 to 200,000 epinephrine ratio. It is one of our long-term or our only long-term drug that's used in dentistry at 90 to 100 minutes of pulpal anesthesia time. Its potency is 4 times that of lidocaine, bupivacaine, and prilocaine. And its toxicity, though, is 4 times less than lidocaine and bupivacaine. It is metabolized in the liver, secreted in the kidneys at less than 16% unchanged. And again, its pKa at 8.1 has a lot to do with its long onset time. This drug is not necessarily used in hygiene because of its long-term pulpal anesthesia, which we definitely do not need. It's mostly reserved for surgical procedures. I'd like to touch on esters as local anesthetic agents and that we no longer use them as injectables. We do use them as topicals, though. They remain highly potent and toxic. When they are injected, they can bring on arrhythmias and also allergic reactions. And you may know them or remember them as the common name as Novocaine, which is still being used in dentistry today, or in the layman's term, when we mention anesthetics, we will just use the coin name of Novocaine. I'd like to discuss the buffering of local anesthetic agents. Local anesthetics are acidic in nature. Upon injection, they cause burning and stinging, and this pH level causes them to be a little less effective. So when we add a sodium bicarbonate solution, we buffer the local anesthetic agent and turn it into a weak amide-based solution. The addition of this water-soluble salt, this hydrogen chloride salt, allows us to elevate the pH of the solution and trying to get it closer to the natural pH of the body at 7.4. This chart was created to help you evaluate all the different local anesthetic agents that are used in dentistry. We have them listed as far as their concentration, with or without vasoconstriction, the name, the street name of them, the pKa, pulpal anesthesia time, and tissue anesthesia time. We will proceed to watch the 7-minute video conducted by Dr. Malamed on the specific agents and clinical actions of them.
What local anesthetics are currently available in North America? At present, there are 5 drugs available. These are articaine, bupivacaine, lidocaine, bupivacaine, and prilocaine. What are the expected durations of anesthesia with these drugs? We can divide these anesthetic drugs into 3 categories based upon the expected duration of pulpal anesthesia. 3 categories are short-acting drugs, providing anesthesia lasting for approximately 30 minutes, intermediate-acting drugs, providing anesthesia lasting up to 1 hour, and long-acting drugs, providing pulpal anesthesia lasting 90 minutes or longer. According to the ABA Survey of Dental Practice in 1999, the typical treatment time for a general dentistry patient is 47 minutes. Treatment time for a specialist patient is 39 minutes. Short-acting local anesthetics provide pulpal anesthesia lasting for approximately 30 minutes. The one drug in this category is bupivacaine 3%. This drug provides pulpal anesthesia lasting from between 20 to 40 minutes and soft tissue anesthesia lasting anywhere from 2 to 3 hours. Long-acting local anesthetics are drugs which provide pulpal anesthesia lasting from 90 minutes up to 3 hours, and soft tissue anesthesia lasting anywhere from 3 hours as long as 12 hours. The one drug in this category today is bupivacaine 0.5% with epinephrine in a 1 to 200,000 concentration. Bupivacaine has a slow onset of anesthesia, approximately 6 to 10 minutes, but provides pulpal anesthesia lasting up to 3 hours and soft tissue anesthesia lasting as long as 12 hours. It is commonly used as a post-surgical pain control medication. Intermediate-acting local anesthetics provide pulpal anesthesia lasting for approximately 60 minutes, and usually soft tissue anesthesia lasting from 3 to 5 hours. In this category, we have Articaine. Articaine is a 4% local anesthetic containing epinephrine in either a 1 to 100 or 1 in 200,000 concentration. The 1 to 100,000 concentration is available both in Canada and the United States. At this time, Articaine in a 1 in 200,000 concentration is not available in the United States. Articaine has an onset of anesthesia of approximately 2 to 3 minutes and a duration of pulpal anesthesia lasting for approximately 1 hour, soft tissue anesthesia for approximately 3 to 5 hours. Lidocaine is available as a 2% concentration with epinephrine in a 1 in 50,000 or 1 in 100,000 concentration. Its onset of anesthesia is 3 to 5 minutes with a duration of pulpal anesthesia of 1 hour and soft tissue anesthesia lasting from 3 to 5 hours. Mepivacaine 2% with levonorepinephrine in a 1 in 20,000 concentration has an onset of anesthesia of approximately 3 to 5 minutes with a duration of pulpal anesthesia lasting for 1 hour with soft tissue anesthesia for approximately 3 to 5 hours. With epinephrine, Prilocaine provides pulpal anesthesia within 3 to 5 minutes with a duration of approximately 60 to 90 minutes and soft tissue anesthesia lasting anywhere from 3 to 8 hours. Prilocaine plain is interesting. If administered by nerve block, Prilocaine plain provides pulpal anesthesia lasting anywhere from 40 minutes to 1 hour. However, if you infiltrate with Prilocaine plain, pulpal anesthesia lasts only 10 to 15 minutes. Why don't patients always demonstrate the expected duration of anesthesia from these drugs? Many factors work to modify patient response to medications, including normal variation from patient to patient, the accuracy of our injection technique, status of the tissue at the injection site, anatomical variation, and the type of injection administered. One factor is the normal variation in response to drugs from patient to patient. This is called the normal distribution curve or the bell-shaped curve. The bell-shaped curve illustrates that 70% of patients respond to a drug appropriately. For example, with lidocaine with epinephrine, 70 out of 100 patients will have pulpal anesthesia lasting for approximately 1 hour. 15% of the population are hyper-responders to a drug. With lidocaine with epinephrine, the duration of pulpal anesthesia for these patients will be in excess of 1 hour. It might be 1 hour and 15 minutes, it might even be 1 hour and 30 minutes. The last 15% are hypo-responders, persons in whom the average dose of a drug does not provide the desired clinical effect. For lidocaine with epinephrine, these patients may have pulpal anesthesia lasting for only 45 minutes, 30 minutes, or in some cases as short as 15 minutes. This is normal and to be expected whenever drugs are administered. What are the maximum recommended dosages of local anesthetics? MRDs, for the commonly used local anesthetics in dentistry, are calculated as milligrams per pound or milligrams per kilogram of body weight, up to an absolute maximum dosage. Other factors which might modify the MRD include the duration of time over which the drug is to be administered and the physical status of the patient. What factors are considered when selecting a local anesthetic for use in a dental patient? The primary factor is the expected duration of the planned dental treatment.
Every appointment will be no longer than 30 minutes. Okay?
Great.
Then you can go back to business. All right?
Once the drug is selected, then we have to consider if there are any medical contraindications to the use of this drug. The third factor is the need for hemostasis. Are we doing a procedure in which bleeding is going to be significant? If it is, then a vasoconstrictor like epinephrine must be included in the anesthetic drug.
Tell me, Clint, do you bleed easily?
Well, I do get a lot of bruises.
You get a lot of bruises.
Yeah.
Okay.
We will be moving now into one of the most important chapters, pre-anesthetic assessment. We must conduct a thorough health history review prior to the administration of any local anesthetic agents. We must assess the patient's physical and psychological state. We must determine if any anesthetic hypersensitivity can occur. We must review the current medications. We must make sure that these medications do not interfere with the selection of our local anesthetic agent. And we must modify our hygiene treatment if we are limited to the amount of drug we can administer. We must know any contraindications with the medication or the conditions that the patients may have with the administration of local anesthetics. We must assess the medications the patients are currently taking. We do not want to create a concomitant drug situation. That is when 2 or more drugs in a patient's system have an adverse effect. They can alter the effectiveness and safety of local anesthetics. This may then change the selection of local anesthetics that we would normally use. We reference the PDR for drug interactions. Later in this course, you will be introduced to a very long 7-page list of drug interactions and appropriate drug selection for local anesthesia. The patient examination is concluded when we have assessed the physical state, the psychological state. We've taken into consideration any risk assessment, any contraindications to the local anesthetic drug we've selected, whether or not we should be selecting a vasoconstrictor, and if this vasoconstrictor has any systemic interactions with the patient's disease, any allergies, any alternatives to the ester-derived local anesthetic interaction, the amide local anesthetic drug-to-drug interaction, and any other amide local anesthetic interactions that must be considered. We want to start the physical examination by a visual. We assess the patient's general health and well-being. We observe their posture, their speech patterns, their body movements, their skin, and their anxiety level. Within the physical examination, we take vitals. We want to assess their blood pressure, their pulse, and their respiration. If an adverse effect were to occur and we were to alarm EMS or paramedics to arrive to the office because of the administration of local anesthetics, they will want to know what the initial vital signs are of the patient. Therefore, prior to any local anesthetic delivery, all vitals are taken on the patient and documented in their chart. We want to determine the maximum recommended dose. This dose is usually calculated and stops at 150 pounds. If a patient is under 150 pounds, we will do calculations to determine what the maximum recommended dose is. The manufacturer had set doses at over 150 pounds, which will be the limit to what amount of local anesthetic we will administer. At this time, Florida dental hygienists do not administer drugs to children under the age of 18. Prior to the procedure, we must evaluate a risk assessment to determine if our patient requires antibiotic therapy. If the level and determine the level of anesthesia. If the patient is suffering from anxiety and needs additional sedation, and if the patient may suffer any allergies from the local anesthetic agents. We also have to determine the level of hemostasis within the type of treatment we're delivering. We need to evaluate the chair position of the patient, what they can tolerate. We also must review their medical history to be aware of any type of drug interaction, any adverse effects, side effects, allergies, or if the patient has any valve, stents, pacemakers, or joint replacements. We also evaluate the type of equipment we're going to use. Will we be taking x-rays, ultrasonic? Is there a need for oxygen? And then we always want to be prepared for any emergencies that may occur. We mentioned in earlier lectures the need for assessing the patient's dental phobia. We must achieve adequate pain control. In doing so, we must avoid producing the fight or flight response, whether it's through the administration of a local anesthesia or through our actions in encouraging this response in our patients. We must reduce the state of alarm. We do know that as the patient enters with a dental phobia that's escalated, they have an increased adrenaline production, an increased heart rate, an increased blood pressure, and increased muscular tension. The administration of local anesthetics also increases their adrenaline production, their heart rate, and their blood pressure. So the selection of local anesthetic agents is very important. And the selection of local anesthetics for this patient may have to do with whether or not we will administer a vasoconstrictor. We must determine this on several levels. Do we need hemostasis? Or will the patient's condition or medications determine the dose? Either one, we go to a lower dose called our cardiac dose or limited dose. With the administration of epinephrine, we only administer a 0.04 milligram per appointment. If it is the synthetic epinephrine levonorepinephrine, it will be a 0.2 milligram per appointment. We want to administer the appropriate amount of drug to avoid any contraindications. Local anesthetic agents, with or without vasoconstrictors, may cause adverse reactions. If these adverse reactions are life-threatening, we classify them as absolute contraindications and we do not administer. If there is a relative contraindication, the reaction could possibly be life-threatening, we proceed with caution and we administer the lowest possible dose, or we select an alternative. Attached to this lesson for local anesthetic interactions is a chart that will select the best drug, relative contraindicated drugs, and absolute contraindicated drugs. This listed by disease, conditions, and medications. Just take a quick look at the following slides and reference the attachment to this lesson. We will conclude this lesson with a 3.5-minute video from Dr. Malamud on patient assessment.
How is the patient properly prepared for local anesthetic injection? Prior to administering a local anesthetic, the patient must be evaluated for their ability to safely tolerate the stresses, both psychological and physiological, involved in the planned dental treatment. The steps involved include a medical history questionnaire, a physical examination which includes vital signs such as the blood pressure, the heart rate and rhythm, and respiratory rate. We will then determine the patient's medical risk and any necessary treatment modifications. The ASA Physical Status Classification System helps us to determine medical risk during dental treatment. An ASA-1 is defined as a normal healthy patient. ASA-2, a person with a mild systemic disease. ASA-3, a more severe systemic disease which limits activity but is not incapacitating. ASA-4 is an incapacitating systemic disease that represents a constant threat to the patient's life. ASA 1, 2, and 3 patients are candidates for elective dental care. The use of local anesthetics with or without vasoconstrictors is indicated. ASA 4, 5, and 6 patients are not candidates for elective dental care.
So if you had a history of high blood pressure? Okay. Well, you're running a little high today. And how about your sugar?
Well, it's about 300 something in that.
300. You know, you have some serious dental problems, but the best thing for you to do is see your physician, get everything medically controlled before we do any work on you.
Consideration for decreasing stress to the patient during dental treatment minimizes the risk of an acute medical emergency arising. Steps to be considered include the following: sedation the evening before or the morning of the planned dental treatment, intraoperative sedation, effective pain control during their treatment, a morning appointment, Time factor. The appointment length should not exceed the patient's tolerance.
Now, we're going to have 4 appointments. I've decided because of your apprehension, we're going to have short appointments. Every appointment will be no longer than 30 minutes.
Hot, humid weather. The consideration for post-operative prescriptions if needed. Post-operative telephone call the evening following dental treatment.
Hello?
Hi, Julie. This is Linda at Dr. Stan's office, and the doctor asked me to call you and see how you're doing today.
Oh, just fine. Thank you. And please tell Dr. Stan I appreciate his consideration.
I'll let the doctor know. Thank you.
Bye.
If you come across any questions during this lecture, please jot them down, send me a text or an email, and I will answer them as soon as possible.